Dear colleagues, good morning, good afternoon, good evening. This is another IMPW day, and I would like to welcome all of you to today's webinar. I'm John Damilakis, and I have the pleasure to introduce an excellent colleague and friend, Professor Hilde Bosmans. The title of her talk is Virtual Imaging Trials in Breast Imaging. Clinical trials in breast cancer screening require a lot of images and take a lot of time. There has been an effort to develop breast models and virtual clinical trial frameworks. Hilde will provide information about the typical components of virtual clinical trial studies, provide information on their validation, limitations, and so on. A few words about the speaker. Professor Bosmans is a medical physics professor at the University of Leuven, Belgium. She's also in the radiology department of the University Hospital Leuven and steers the quality control procedures in 103 mammography units in Belgium. Ongoing projects in virtual clinical trials in breast imaging focus on the creation of synthetic imaging for AI, artificial intelligence training, the optimization of contrast-enhanced mammography, and expansion to other modalities such as chest X-ray imaging and cone beam dental applications. I think the topic is very specific, very advanced, very modern, very interesting. And before I give the floor to Hilde, I'd like to thank Dr. Magdalena Stoeva for supporting all IOMP webinars, technical support, and information dissemination. It's not easy, and we are all grateful for Magdalena's hard work. So, Hilde, we have something like 45 minutes for your talk, and then something like 15 minutes for the discussion session. The floor is yours.
Okay. John, is it correct that my screen is now
Perfect.
As it should be?
Yeah.
Thank you very much, dear ladies and gentlemen from all over the world. It's a big honor for me to speak to you. And before I start my presentation, of which you can, in the meantime, enjoy the title, but before I start, I would like to thank, first, John Damilakis and his whole team, including Magdalena, for all the magnificent work that they do for the medical physicists in the world. I think it is a big task. It is very good that he takes care of this. So I'm very grateful with all the effort he puts in this. And then the second reason to thank him, of course, is for having contacted me and asked me what would be my preferred title to talk about. And well, here I can't complain about whatever workload, because what I'm doing now, what I'm going to do is just talk about a topic that I really like. The topic is virtual clinical trials for breast imaging. My colleague Nick Marshall has recently done a lot of literature, and obviously we've discussed even the type of made state of the art. But in this presentation, I'm going mostly to speak from our own experience. And that is why I'd like to start with, with acknowledgement first. First, acknowledgement to several, mainly PhD students who have worked at VCTs. That's how I will abbreviate it, virtual clinical trial of VCTs. So PhD projects or master thesis projects, and PhD students then with their master thesis students. So without their work, there would not be a presentation here. And the other groups to acknowledge are all the people, the research grants that we got and that enabled us to work at it. Also the manufacturers who were very eager to work with us, who give us grants as well to develop certain things, who are still doing this. And also the international scientific cooperation and the many, many discussions with several groups around the world. Let me first more or less introduce the topic. And I would like to start with the historical trigger for this work in my team. And it must have been around the year 2000 when digital mammography was developing, that at a certain moment we were asked, or we were confronted with several image processing algorithms and vendors claiming that this one was better than another one. And we were asking ourselves what would be the impact of a new image processing algorithm on breast imaging, and even more specifically on detectability of microcalcifications, because early on we had understood that detectability of microcalcs is probably going to be a most critical part of the job. And there you are. How do you, how could you possibly test the impact of a new processing algorithm? There is a straightforward answer, and that's this one, with a clinical trial. And then how would you then do this? Well, you would try to find cases with subtle, proven microcalcifications or clusters of microcalcifications. So not just a cluster, but the subtle ones, the difficult ones, where you could find the difference between different processing algorithms. And then you would want the cases to be representative for the population, representative for the breasts in the population with this given density, with the thickness, representative of the dose setting on the system. If you are lucky, you had collected raw data over the time, and you can go for a retrospective study and just pick these cases with subtle microcalcifications and reuse these to test image processing. But very often you would have to go for a prospective trial, which will take longer because you then depend on which patients or women show up, and you would have to maybe do an informed consent study. The whole ethical committee approval would be more difficult and so on. And the costs start to increase, you know. It would also cost you time. You would need the approval. You would have to find co-workers who would want to help you. You have to acquire the images, to prepare the study, to read, to score the images, process the data, and then probably make the reports and a paper. This is very time consuming. Here is an actual trigger for a VCT, and that's this, for instance. Is there a way to improve synthetic mammography? Now, just between brackets, what is synthetic mammography? Well, you probably know digital mammography, which has a tube perpendicular to a compressed breast and makes a 2D projective image. Tomosynthesis makes such types of projective images over a certain angular range and has different projections in between this, and then creates a pseudo three-dimensional stack. And this is obviously not the breast. This is an image of a test object, and this is the breast tomosynthesis acquisition of the same test object. And out of these either reconstructed slices or the original projections, the vendors now also calculate what is called a synthetic mammogram that looks like this and is pretty similar to the digital mammography image, but it's not the same. And there are several uses for the synthetic mammography, and there is a type of a push towards getting it really good. And then the question is, how would it be best? Here, just some extra information that is in fact what it is. And the synthetic mammograms, they can be used, for instance, for comparison to 2D mammograms, for a quick overview, to assess density, maybe to check symmetry and positioning for follow-up in time. And so maybe it could replace DBT reading by synthetic mammogram plus computer-aided detection of the DBT stack. Who knows? So there are good reasons to try to get it better. if we then consider which types of parameters would come in, there are even many more than in the previous set of where you just want to compare two processing algorithms on a 2D mammogram. Here are just a few. If you want really to improve the synthetic mammography, it starts with improving the tomo. So you start considering angular range, the rotation, propulsive step and shoot or not, the number of projections, the reconstruction parameters, the reconstruction algorithm, the slice thickness, the slabbing, the beam quality. I mean, this is endless. And if you really want to know it, then for every possibility, you would have to do a clinical study just with all these types of combinations of parameters. This is where virtual clinical trials comes in. There is a practical solution to the type of studies we have just suggested. What is a virtual clinical trial, or what is it? Then you make a framework, you validate your framework, you make a virtual patient, you validate that patient, you make, and the patient needs obviously some pathology, then you make a model observer who's going to read your virtual images, you validate it, and if you have all these pieces nicely set up, you can run an application. And okay, you make your virtual patient, you make the virtual image, and you make a virtual evaluation of the results. And all this sets up a virtual clinical trial. Obviously, this validation is needed, and there's still some missing step maybe, which is you can do it all virtually. In how far will it then predict the reality? But a virtual clinical trial can be used to solve many questions or already sort out what are the parameters of benefit. So here is it in a more symbolic way. So a real clinical study would start from a patient, would start from an acquisition, would start from images and a doctor reading it. Whereas in a virtual clinical trial, you make your virtual patient, you program or you calculate the X-ray image that is the result, or that would be the result of your virtual patient. You get virtual images, and then you apply some virtual expression of the quality, a signal, an evaluation of the signal of your pathology. There are now two big options to address it. Here's the first option of this virtual setting. You simulate the X-ray system, you simulate the patient, you simulate the lesion, then using all these three components, you create the images and you apply a model observer. You could also just have human readers observe the virtual images if you wanted, but if you go the whole way through, you do it with a model observer. The big advantage is that everything is simulated, so you can basically do it in your lab. You do not need this fancy device somewhere in your hospital. It is virtual. You just need to do a lot of work, have a computer, and calculate through the whole chain with your computer. And by the way, I'm not going to stress it too much here, but on the internet, in the scientific literature, there are pipelines that can be used or that are available for us to use. One of the most famous is the one of the FDA, the so-called Victory pipeline. What is the disadvantage? The disadvantage is the link with reality that can be a bit far away, because it starts with, well, everything is simulated, and it's not always trivial to simulate really a patient. There is a very good example of this approach published in the JAMA paper, and the title of the study was Evaluation of Digital Breast Tomosynthesis as Replacement of Full-Field Digital Mammography Using an In Silico Imaging Trial. First author, Aldo Bodano of the FDA. And so what they had done in their study is there was a clinical trial comparing here tomosynthesis to full-field digital mammography, and they have done the simulated alternative of this, and the conclusions and the relevance is interesting. This is literally a copy of their paper. The results of the simulated victory trial are consistent with the performance seen in the real clinical trial. They recognize that there is further research needed to assess whether this is now a generalizable result, or whether it is just for the Siemens system that was simulated. But they say that this in silico approach, since it really predicts clinical results, that it is a viable source of regulatory evidence for imaging devices. So from the FDA, there came an opening towards using these simulated approaches for regulatory aspects or regulatory parts of an imaging device. And here is more in practice what they had done. They have simulated lesions into breast tomosynthesis, and you can see here an example. And they have also simulated the same lesion in a 2D acquisition. So this is the tomosynthesis, and this is the 2D. And they have then basically compared the detectability of the lesions as a function of different parameters. These are, by the way, simulated images of a simulated, completely virtual breast. And they have seen for which aspects DBT versus digital mammography would be best. You see that for all aspects, DBT is actually winner, and for the detection of microcalcification, it was not significantly different, but DM had a somewhat better score. I'm sorry. I'm sorry for I wanted to switch off my. Option 2 is a bit different. In option 2, we start from real images, and more in particular the raw data of the real images. And this means, in fact, the images like they are acquired by the detector before there is any processing that went over the image, so the raw image. We simulate lesions into these images following all the physics. So that makes us hybrid images. And then we reconstruct these images with a tool by the vendor or with our own reconstruction box, and we apply on these images a model observer. Advantages are trivial. There is no need to create the background images to really create the whole patient. We would have to create the lesions, of course, to merge them with the images, but there is no need to create the background images. These images are really easily realistic if you do it correctly. And there is obviously a disadvantage, which is you need these images. So you cannot just do it without having access to images. And this is how that goes. It starts from real images that you get from a PAC system or from the internet, from data sets that are available. You make a model of a lesion, you fuse these physically correct, so taking into account the attenuation coefficients and so on. So insert them, you get a hybrid image, you reconstruct it, and then you can do, for instance, a detectability study. What are applications for this type of approach, either option 1 or option 2? Well, in my practice of medical physicist in a radiology department, I try to listen to the questions of our radiologist, and we try to answer their questions or to do optimization of their devices following their request. Here are a few questions that I was asked over the years. For instance, the one I started with, it's historical also, so it started all with this, can you say something on the quality of the image processing algorithms that are being invented and brought into the market for 2D mammography, both for CR and DR applications? Can we compare DR and CR technology for 2D mammography? Can we compare the quality of the viewing stations? How about a new dose setting for the breasts? Can we compare 2D mammography and breast tomosynthesis? Can we assess the effect of dose on detectability of calcs and masses in tomosynthesis? Can we compare or optimize the synthetic mammography versus FFDM? And there are many things to come, dual energy, new tomosynthesis approaches, breast CT, maybe 3D dual energy. I don't know. Question. There is the future has not yet stopped. It will continue for a while. So all these questions that came from clinics have been addressed in the frame of several research topics in my team, and I'm very glad for this. I've not done it myself. I was happy to work with many young people who are very enthusiastic, who have worked hard. You see here the people who have, of which I will discuss some of the topics here. Okay, so how do we start at such thing? What are the different tasks? First, you need to describe your problem, and in terms of physics, you may have to contact manufacturers, for instance, to get access to these famous raw data, or to get access to a processing routine to process the data, or to reconstruct the projections of a tomosynthesis set, for instance. Then you have to collect the images. In our case, when we go for option 2, we have all to write some software code for this. We need these 2D and the 3D models of lesions. 2D, if you are okay with the projection. If the study is just 2D mammography, then a 2D projection of a 3D lesion is probably fine. Otherwise, you need a 3D model. We need to validate our software and then apply the study. And that has 2 parts: run it and then either do a model observer or a human observer, and then you conclude with your report. There are therefore several components. You need database of images, you need models of lesions, you need a tool to simulate the lesion in the raw projection, and then to reconstruct your projection until a 2D image or tomosynthesis reconstruction. And then you need something to view your images, and an observer to look at these images and to score these images. And some insight and some experience with statistics is, of course, a big advantage. And then you report, and maybe I should have added here webinar. If everything is fine, then you may be lucky to get the invitation for a webinar. So let me go over the creation of these parts in our team. This is how we started, with Ann-Katherine Carton doing a meticulous job of selecting in digital mammography images small calcifications, and then making templates of these calcifications with, in fact, finding or defining type of rings with the same intensities in single microcalcifications. And then she made tons of them and grouped them as a function of size. Federica Zanca did it in a different way. She started from high resolution images, or we can say high, not super high resolution, just very high quality images of different clusters of microcalcifications, of which she made templates. And these templates were then further tuned to have them either more dense or less dense, depending on the application. Another way to create a model is acquire micro CT scanning of, for instance, microcalcifications, and that is what Shaheen has done here. We need also models of masses, and in this time, well, we started, for instance, Emmy started here from MRI images from which a core of a mass was delineated, and then she grew spicules on these cores in different ways. From observation, we had seen that some masses had only a few spicules, some masses had really many, and all these types of masses were created. I must tell that at this moment, and I forgot to include it here, we have also artificial intelligence approaches, in fact, GANs, that help us also create more masses. Here is another way, also an historical way in our team, still one of the best approaches, I think, for simple lesions by Lesley Cockmartin, where we added in a box of oil. We have added, as you may see here, a lesion of glandular tissue equivalent material, for instance, a sphere, and then an acquisition with and without a sphere allows you to find the added gray values due to the sphere. So this is basically a subtraction method, and the same subtraction method was also used to find the models of the calcifications. What you see here is a thin PMMA plate that was provided by Leeds test object that had clusters of calcifications with different sizes. And again, we did the subtraction method, and in the subtracted image, it was possible to extract the templates of the calcification. It was a meticulous job as well. Then once we have lesions, and I just repeat, it is possible to now multiply the amount of lesions by applying AI techniques on all these different models. That's done also. Then we need simulation frameworks, and there are also several approaches there. For instance, if you start from a template of a lesion acquired on a particular system, versus in our case was a magnified view on a CR system with a certain beam quality. This template was calculated into a template for an ideally sharp digital detector by applying the inverse of the MTF. Then it was switched, it was calculated with what the contrast would compare in terms of aluminum. And then this amount of aluminum was expressed in the amount of aluminum on another, for another beam quality. And then this was then brought back into the original template. And then we had the template to be put in an image taken with the beam quality to which we had been working. There are other ways, but in fact it comes always down to the same principle, which is ensuring that the projection of the lesion is in line with the image system for which you want to make the lesion, and then merge it with the raw data and have it processed. It is absolutely necessary to validate any newly made simulation platform, or even to validate a simulation platform that you may use of other groups, but then for your particular application. And what you see here is just a list. It's not important. It's just showing that there are many where we, in fact, ask most of our PhD students first to do a validation of at least a part of the simulation platform. Another thing to be validated is how the lesions show up. The lesions should be sufficiently realistic, and that is typically done by showing the lesion in an image on a mammography screen. Now let's come to the applications, and in this part, this is the second part of my presentation, I will show you just a few results that we have acquired with this approach in our team. I'm sorry that I did not include the whole literature. I really hope that in a couple of months from now, Nick Marshall's review paper will be online, and he carefully explains what other groups have been doing. I just wanted to show in my way what we have tried to do. So we started in the early 2000s with Ann-Katherine Carton, where we had access to Fuji CR images and to Agfa CR, and also to an Inspiration DR system. We had 104 ROIs in which we had put simulated calcifications of different diameter and thickness. And you see here in this cloud all the types of calcifications that were used in the study. You see that's more or less randomly, but more or less homogeneously distributed in the thickness size space. So then all these calcifications were put in the many different ROIs in the image, and the readers, in this case human readers, were asked to click on these places where they thought there was a calcification. And by the way, these were the early times of digital mammography, where in fact digital mammograms were still printed, and the readers basically marked on an overlay paper where they had seen the calcification. The nice result is shown here. We have two readers reading the images of Fuji CR and the Agfa CR, and you see that there was already an outperforming at that moment for the FUJI-CR, which had the double reading system in comparison to the early phase single layer phosphor CR. What you see here is the detected fraction of all the simulated lesions as a function of the false positives. In the same effort, and it's printed in the IWM 2006 edition, we have here 3 readers, and all 3 readers saw detected fraction of a DR system much better than for 3 CR systems. So already a first indication that DR, digital mammography, was going to outperform the CR-based acquisition systems. By the way, so this work was printed in IWM 2004. You can still be part of the IWBI 2022, which is going to be next week, end of next week in Leuven. The next application was a comparison of processing algorithms. And this study was done by Federica Zanca. She started from a large number of raw data, more than 100, I don't recall the exact number. And we gave these raw data to, in fact, 4 vendors, and 1 vendor having 2 different image processing algorithms. And what you see already here is that although the raw images were identical, the look of these images depended really a bit on the processing. And these images were not just images. In these images, she had simulated microcalcifications. Again, we have been focusing on microcalcs because they were so critical. So here we have a set of identical raw data images, all with the same simulated lesion, but processed with different processing algorithms. And again, readers have been reading these images and have tried to find the simulated clusters that Federica had put into these images. The readers obviously did not know where it was. It was a free search experiment. And here we have again on the y-axis the lesion localization fraction, the higher the better, as a function of the non-lesion localization fraction. And she obtained the best result that you can have as a PhD thesis, a PhD student in your thesis, which was an older software of the manufacturer of the device of the images performing not so nice, but the newer software being much better. And in between were the processing softwares of the other vendors. And okay, that was probably more or less what we had expected and what was a logical result. Another application has to do with testing the impact of the level of luminance of the monitor. And more in particular, in this study, we have asked readers to look at regions of interest of mammograms shown with different amount of candela per square meter on a high quality barcode monitor. Here is the type of images that were created. I think you can recognize a mass lesion that was simulated into, always our way, into real images. But here the mass lesion was given different sizes, so from large to always smaller, so always the same mass, but just in size going slower. And here you see also the same mass, but going from very dense to less dense. In this case, the type of experiment was a 4 alternative forced choice, which means that the reader saw at every moment 4 regions of interest and had to click on the region of interest with a lesion. And here are the results of this study. Here on the x-axis, you see the luminance level, and on the y-axis, you see the percentage correct. So of this 4 alternative forced choice experiment, and what you see here is a result of which we were shocked at first, which is the luminance did not make a difference. It is only when we also looked at how much time the reader had required to come to his click on what was okay, that we started to see an impact of the luminance level. And here you see that the time to come to a decision was much lower for the high luminance than for the lower luminance. So suggesting that if you make the luminance level high enough of your monitor, that you will gain time at the end of the day. And the next student, Alale Rashid Nazat, did around the same time. You see that we become more and more up to date, not, but more and more recent. She did also study with monitors, and here the question was, what was the impact of the best display device versus some somewhat lower quality devices? This study was also an enormous study in which she started from an enormous amount of regions of interest shown on a standard monitor and on an advanced monitor. And you see that the percentage correct had a large spread, but the mean values showed that the advanced monitor indeed outperformed the standard monitor. And here the nice thing is you can plot this as a function of size. You can plot this as a function of the density of your lesion, and you can also plot it separately for the different glandularities in the background image, where you see, for instance, that when the glandularity is low, I mean, when the breast is the breast, the region of interest was from a very fatty breast, adipose breast, then the detected fractions were higher, whereas the detected fractions were much lower when the tissue was more glandular. Such type of an analysis is really not possible if you depend on just the cases that come to your hospital. This amount and this statistics is only possible if you can create thousands and thousands of images, which he had done indeed. A next application checks whether there could be any good reason to change or to adjust the dose level given to the women. And what we had seen is that with those levels represented here by the open squares and the open triangles, that all the physical measurements of detectability show that detectability would go lower for the thicker breasts. With the closed squares, this is the dose level that guaranteed that the physical measures of signal difference to noise ratio would remain similar over the thickness range. Here we have then done such a study. We started from the first situation, like we had seen the system arriving in our hospital, with those levels shown here in blue, this purple, green, and the other purple version. And then we did also, during a couple of months, we worked also with a system at somewhat higher dose, which theoretically, physically spoken, would come to the same detectability results. So this is a type of images we created here. We had simulated masses and calcifications. We put a type of mass in a thickness 22 millimeter breast, 36 millimeter breast, 59 and 77. And then we had also the higher dose versions where we included similar lesions. Here is the result. In the setting like it was suggested and installed by the manufacturer, we saw that the detected fractions were higher in the thinner breast than in the thicker breast. And this was in line with what we had seen with our SDNR measurements. So we had seen a higher score for the thinner breast and the score going down for the thicker breast. Well, here is the result after the adjustment of the dose level, where still the thinner breast had a better result, but that was because also physically the score, I had said the SDNR identical for all the breasts was not completely true. We did not change the first group, which actually had a higher SDNR, but all the other groups came to the same lesion detectability, which was, I think, an amazing result. Here we are showing another virtual clinical trial study in which the same type of calcifications. You see here calcifications ordered in groups of 5. The same calcifications simulated into 2D mammography and into digital breast tomosynthesis. And here are the results at the left for the masses and to the right for the calcs. We see here the scores of the 2D mammography versus the tomosynthesis, and always better means higher curve means better situation. So we see DBT outperforming for the simulated masses and 2D outperforming for the calcifications. Be aware, this is not a study of last year. In the meantime, this study is nearly 8-9 years old, and at that moment, indeed, we were triggered to work even more at the calcifications, because especially in the beginning, DBT was not at the same level as 2D with regard to calcs, but there was a definitely better performance for the masses. In the meantime, we have not repeated exactly this study, but we've done other VCT studies showing that DBT and 2D come at the same level. But such type of approach with the simulated lesions and all types of ROIs in the image allows analyses that go beyond what you can do with any clinical trial. For instance, you can check area under the curve or detectability if you want as a function of microcalcification size, or you can do it as a function of density. You can do it as a function of thickness, and always for 2D and tomo. So if you have this massive amount of readings, human readings or model observer readings, it is then also possible to do an analysis or plotting of the data for many different parameters. A next application tested the impact of the so-called PRIME option on a Siemens digital mammography system. PRIME reduces the impact of scatter radiation by a software application. And what we have seen here, again with simulated lesions, that the application of PRIME seemed to be a little bit better. It was not, the difference was not very high for the thinner breasts, but was surely not better for the thicker breasts. So there is a type of a turning point where PRIME could be used and where PRIME should not be used. And this is the last application I want to show you, done by Liesbeth van Coillie, and it is still in the process of being presented and being published, where we compare the detectability that you can achieve with synthetic mammography versus tomosynthesis. So you see the digital tomosynthesis here at the left. You see a template of a lesion and how that lesion integrates with the environment. So tons of, no, not tons. This study basically used only 8 patient data, I think, if I remember correctly. But from, of course, one patient, you can define several regions of interest. So with a limited number of patients and a nice collection of masses, it's possible to hide masses in this tomo and ask viewers then to detect them. And you can simulate the same or another type of mass also in the digital, in the synthetic mammography. Here you see what Liesbeth started from masses that were made, in fact, with our AI approach, and also calcifications. So the virtual clinical study was as follows. So we started, as I said, let me quickly think. So 8 cases in which of tomosynthesis, of which we had the projections. She has simulated calcifications into these projections and also masses. And then our question was not only to compare synthetic mammography to tomo, but also to see whether we could improve the synthetic mammography. So she simulated the situation with just the same dose over all projections, or a dose that was lower at the periphery and somewhat higher in the center, and then also situation with more sparse. So at a higher dose per projection, but less projections. You can see how can we start from one patient case and simulate something like sparse projections by keeping the total dose the same. Well, the answer is in physics. You start from a projection, and it is possible after careful calibration and validation, to simulate how the image would look like at a different dose level. And then, yeah, then it is possible to simulate how the image would look like for instance, a sparse setting. Must be said that we started here from a selected number of cases where the dose, the initial dose, had been increased to like somewhat less than double. And that allowed us then to simulate the impact of the sparse projections and also the impact of a normal situation. Here you see how this typically looks like. This is a DBT run at AAC with the normal projections, but here we can do convex, so somewhat higher dose in the middle, less to the periphery, and also sparse, just selecting less projections, but the same total angular range. And we did this for, well, not we, I mean, Liesbeth did this for DBT and synthetic mammography. And then we get curves, for instance, like this at the AAC for DBT and simulated, and you see that, yeah, one after the other. In fact, the AAC choice, the classical choice that came with the system, in fact, was the best for the DBT, and synthetic mammography would be helped a little bit with focusing a little bit more dose to the center of projections. And from this, we come to some conclusion. First, that DBT was still outperforming synthetic mammography, so no way that we recommend anybody to just use synthetic mammography. No, it should still be used in combination with DBT. And then also that this convex dose distribution with a little bit more dose to the central projections and a little less than, of course, the peripheral can lead to an improvement in the synthetic mammography. Also, we did not see a good reason with regard to the detectability of calcs and masses to go to a more sparse distribution. So I come at the end of this presentation. I took a few more minutes than what John had asked me to, but this is just a quick summary of the applications I have shown to you. So here I will put it in words. I think with our option 2 VCT, which is starting from real images and simulating lesions into this, we could at least provide some, at minimal, preliminary answers to some of the questions of our radiologists. Most projects have been done in cooperation with industry because they accepted to either reprocess these images or to share their monitors or come to see us with also formulate some interesting questions. Most of the results have been presented at conferences and are also available in PhD manuscripts, which you can get from me if you want. Virtual clinical trials have to be done carefully. Virtual clinical trials are at first not a fast solution to a question. From the initial idea, the question by the radiologist, until we have an answer, it typically takes a PhD project, which in our country is 4 years. Of course, once all steps are validated, you can easily think of more applications, or by the end of a PhD project, you can do more than just one application. If you're really interested in this topic, then it's a bit late, of course, but we organize, as I've said already, the International Workshop on Breast Imaging, and this workshop starts with a virtual clinical trial workshop. So yeah, you can check out here our website. We will put a few files, a few lectures also online, so just follow us, or if you can still do it, join us in Leuven, why not? I thank you for your attention. I welcome the questions if you have any, but it's to John to moderate further the session. This is just a leaflet showing that we have indeed this IWI workshop, and there is now a program book available on the website. I thank you very much.
Thank you, Hilde. Very, very interesting presentation. 430 fanatic colleagues. I'm saying the word fanatic because nobody left. So
wow, yeah, I was going to ask how many did I lose, because I did not see this number.
Nobody.
The counter.
So
Thank you
means
very
that
much.
it was very interesting and people are interested in this topic. So there is one question in the Q&A section, and then I have also a couple of questions if there are no questions, additional questions from the audience. So the question is, for this VICTRE study, were the lesions included into the final simulated image or already into the phantoms? And how is the simulation done in this study? Is it completely done by Monte Carlo?
Yes, thank you very much. This is a very nice question, and indeed I have not told this in detail. In the VICTRE study, it starts from a 3D volume that represents a breast, and in this 3D volume, the lesions are replacing the normal, the voxels of the normal tissue, and then this 3D volume with its lesion already integrated in the breast is being projected with the Monte Carlo. So a very important part of this VICTRE platform is indeed the Monte Carlo simulator. That Monte Carlo simulates the projections of all these breasts. So it's an enormous platform, and I highly recommend everybody to, if you're interested in this research, to go and have a look. And it's high time we create a users club, I think, using this platform. And then the next question.
Why would detectability be low for thicker breast?
Yes, that's also a very good question, and it was, in fact, that was my, I would say, personal concern. Starting from physics, like I tried to explain, if we did whatever test we would invent, SDNR or model observer or CDMOM score or other scores in physics, we always saw that the detectability or the score was lower for thicker breasts than for thinner breasts. And why is this? Well, the easy answer is, I think the manufacturers have put the dose to the breast. I'm not sure I can say too low, but at least relatively low. We have shown that it is possible to define the dose with which we can get to the same level, but the systems are delivered with a type of other curve. Of course, there is some reasoning behind this, and that's where our physics is failing somehow, which is or is limited. If we test with PIMA-made plates, we can test for the thickness, but we do not test for the structures of the breast. And so that is why I never dare to make a strong point to the manufacturers, like you have to increase the dose. No, because we didn't know then, thicker breasts usually have more fatty tissue and are a little bit easier to read. So manufacturers would come up with the argument, look, it's thicker, but it's easier. And that's exactly why we wanted to do this research, to see which would work. Is the thickness going to decrease more, or is the easier tissue type of compensating? And we have in fact shown that with this VCT approach, at least the study has also limitations, but within this VCT approach, we have shown that it is better to bring the dose to a level of identical detectability if you want detectability to be the same regardless of thickness. So my short answer is, why is detectability lower for the thicker breast? Well, because the dose setting is very low, or maybe too low.
Could the virtual clinical trials be used to develop phase contrast breast imaging techniques?
Yes, I think that's indeed possible. Of course, you would need another platform than what I've introduced to you. In my team, we have made a simulation framework for phase contrast imaging. I recommend to check for the paper by Janne Vigneron. You can always write me an email if you want to get her PhD manuscript, which is an excellent way. Yes, it is indeed possible, but it's a little bit a different setting, of course. It's a different platform. I think for most physics systems or more devices, it's maybe possible to do a VCT, but you put some effort in making the platform.
There is another interesting question. Were you able to simulate the lesions taking into account their effect displacing other tissues in a compressed breast?
Yeah, that is a very, very good question indeed. In our approach, it is not possible. Yeah, we don't change in our approach in which we simulate lesions in the breast. Yeah, no, we don't do it. But it is indeed a limitation, but very often when it comes to optimization, we may not be interested in seeing the big lesions. We are often interested in finding the small masses and the subtle calcs. So in that sense, it is not always a big limitation of the method. But this being said, if you would have the idea or the means to simulate indeed the tissue being pushed away, that would be great. What people do now, and there are a couple of publications where they can simulate growing cancers, but also that's a growing cancer in the environment, but it's also not yet pushing the tissue away. Of course, if you go to option 1, which is starting from a real breast, a 3D volume, then it's probably easier. And now option 2, simulate lesion in a given background, that cannot be simulated, or at least I would not know how to do it.
There are no other questions from the audience, so it's time. It's my turn because we still have 3 minutes, so I'll take advantage. I have many questions actually. Time is limited. So one question is, could something similar be done for CT screening or CT in computed tomography?
Yes, of course. And in fact, at this moment, the biggest, as far as I know, most experiences in the group of Duke, where they even have a virtual imaging trial center at this moment of imaging trial center, and their specialty is with CT. Intrinsically, I think the difficulty is similar, but what comes on top of a CT scanner is the difficulty to extract the projections, so the raw data, where in a mammography device, you make one projection, and maybe with Tomo you make 25, say something, but it's one raw image or 25, but you export to the images, whereas in CT, you export a type of a format of a spiral CT of I don't know what. So this aspect of extracting the raw data and then reconstructing them with the reconstruction algorithm that looks to what you have in practice, that is the more tricky part.
Actually, we have started doing something similar here.
Yes.
By embedding tumors and other pathologies into virtual fandoms. And it is interesting.
Yes, it's for sure.
I have another, I feel that AI has a major role here. You said something about GANs, about adversarial networks for simulation, for creation of lesions and images. How far can you go? I mean, my experience shows that using GANs, it's fine. I mean, for example, for those prediction, is okay, but for image creation, it's a little bit tricky. What is your opinion? And are there any other ways? I mean, what is the best approach, in your opinion, for image, for synthetic image creation using AI?
Yeah, thank you for the question. Yeah, we are also working into this direction, and I'm not sure I have all the answers. AI always requires a lot of input data, and okay, that's what we try, for instance, to give to a GAN, a lot of models of cancer, and then hopefully this is enough to start creating reasonable new models of cancer. The same you can, yeah. if it comes to creation of breast, the problem a bit at this moment is that we do not have a massive amount of 3D models of a breast. Now with breast CT, it will come because these scanners start to be installed here and there, and they create these 3D volumes. I mean, there are a lot of tomosynthesis data, but that's not 3D enough. That is pseudo 3D. In plane is very high resolution, but through plane is just not 3D. So that's probably not enough. When a massive amount of breast CT models will come, then maybe at some point we have enough of them to start creating the real breasts. There are also papers out that start from a massive amount of 2D mammograms, where there are also enough trying to create other 2D. I think at this moment, testing for the realism of these images is very important. At the other side, it must be said that there may not be that many applications where a really very, very, very realistic breast is necessary. I think you need some texture, but I'm not sure you really need to mimic a breast for the majority of the questions. For some questions, yes, but for the majority of the questions, just a structure is probably enough. And there, AI may be well placed, but probably every VCT will have to start with carefully telling what you aim for, what are the limitations, how you get to your data, such that the whole thing is well understood. And it will remain a technical study at some point. But avoiding that we have to do for everything a real clinical trial. It's just too time consuming, and by the time the study is over, the studies may be outdated. We want to go faster.
I like the physiology clinical study, virtual clinical study, virtual imaging trial, virtual clinical trial. How about a simpler term such as virtual optimization, for example?
Yeah. Yes. Well, yeah. I mean, the main application may be to get through the regulatory aspects, but for optimization, maybe all our studies have been more in optimization and finding the place of specific modalities. And yeah, and we started the tradition more like virtual clinical trial, but Ehsan Sameh at a certain moment said, no, it's not a clinical trial, it's a virtual imaging trial. And maybe that is more correct. For once, he's more correct, I think.
I think so.
Once more, he's more correct. That's what I want to say. Usually, he's right.
Or even simpler terms could fit the purpose. Anyway, I'm afraid it is time to close.
Yeah, maybe I want just to add that I made a lot of publicity maybe for the Duke Center, but the other pioneers, in fact, in this domain is the group of Pennsylvania, the group of Maitland and Bakic, who did the great work also. And then in Varna, we have the group of Kristina Biznakova doing also a lot of very nice work in this setting. So, but I had them on my acknowledgement because
there are a few teams, and the number is increasing, I believe. It's a hot and trendy topic.
Yeah, maybe.
So Hilde, many thanks for this very, very interesting presentation. I would also like to thank the audience for questions and for attending.
Yeah, maybe John, if I can add that if people are interested in this talk, there are UTMP courses dealing with this topic. I forgot to put it on all slides.
Just to inform people that UTMB, because of the pandemic, postponed activities, obviously, because UTMB organizes courses, modules on medical radiation protection, and dosimetry, but because hybrids, most of the modules and sessions are hybrid, face-to-face and online. Because of the pandemic, the events were postponed, but hopefully very soon we'll start again activities. So if colleagues are interested in UTMB, they can visit UTMB's website.
Yeah.
Great. Thanks a lot. Thank you, everyone. See you tomorrow.
Bye-bye.
Bye-bye.